Good afternoon, everyone, and welcome to today's Epicenter Psychosis Speaker Series. I'm delighted to introduce our distinguished speaker today, Dr. Janis Jenkins. Dr. Jenkins is a professor in the departments of psychiatry and anthropology, and also the director for the Center of Global Health at the University of California at San Diego. And for those familiar with her work, which I imagine many of you are, has probably produced more textual pieces on the subjective experience of schizophrenia than I think really anyone else here. So is truly an expert in this field here. I myself personally in my own career was lucky enough to benefit from much of her work, where as a graduate student, I got to do some secondary analysis on the COSAMA data set that she and Marvin Carno worked so hard to collect, looking at the experience of Mexican-American families caring for relatives with schizophrenia. These days, there are many papers of her I like, but the one that I find myself handing out to others and demanding they read most often here, because I'm particularly excited about it, is her paper with Elizabeth Carpenter Song on the cultural conundrums and recovery from psychosis, and this idea of how we manage improvement, but where there's no cure. And today we're very excited to have her speaking on her work around subjective experience of stigma and discrimination among individuals with psychosis. As always, we'll have a Q&A at the end of the session here, and people can submit their questions in the chat to me, and I will serve as moderator at the end for that. For those who may be looking for it, as always, we also have closed captioning available, which you can access by clicking on the bottom of the screen on the live transcript or CC button there. And with that, I'm delighted to turn things over to our distinguished speaker today, Dr. Janis Jenkins. I think you might be on mute, Dr. Jenkins.
You know, you would think after, okay, let me get to the beginning of this here. You would think after all of the, over a full year of being in pandemic, everyone would have down completely what, sorry about this, what the need to unmute oneself is when we are living on Zoom, but that's a funny thing. Anyway, thanks very much for that introduction, Nick. Dr. Breitbart has a fabulous career, and I am very happy to join with you today to speak together about subjective experience, particularly as it relates to early onset psychosis. Over the years, over the decades, I should say, my colleagues and I have conducted several, mostly NIMH supported research projects that I'll be drawing on a little bit here and there. Before getting started, I thought I'd take a minute to say a moment to provide some information to you, should it be of interest, about our Center for Global Mental Health at UC San Diego that we started in 2017. We are dedicated to mental health for all across the planet, and have several research projects, about 20 projects across campus within the med school and other divisions across campus. We do a variety of events, speaker series, and training. Also, we have a significant training component within the medical school and also the social sciences. And we also provide news and information about mental health, since we are promoting this and having a focus on it, to draw attention to the importance of mental health, to the importance of getting care, to the importance of treating social stigma like other forms of discrimination that are so very harmful, and to work together to turn that in the other direction. And here's one recent, well, it's not that recent, from September of last year, piece of news that we were highlighting about Daniel Prude. I'm sure most of you are familiar with this case. He was killed while being in an apparent psychotic distress and episode. And this draws attention to the need to be able to identify persons who may be in great distress and how to handle that. We have currently, our active research program includes studies that we're doing with children and adolescents and families in the border zone. Since we are in San Diego, we're 20 minutes away from the border, and we have several interlocking studies that we've been doing in the last few years and are doing currently. I have done a lot of work, excuse me, with adults, but more recently with children and adolescents, and as it's happening younger and younger all the time. Right now, we're working with 11-year-olds in middle schools within Mexico, and also on this side of the border in North County, San Diego. And these are some of just to provide you with a map here, these are some of the zones that we're in here on the West Coast. This is the border here. We have studies in northern Mexico, in the Tijuana metropolitan region in San Diego, in North County, San Diego, and really all along the border, particularly within New Mexico, all over the state, including Las Cruces, which is very close, about 30 minutes away from the border here, and up further north in Albuquerque. This is a recent publication about adolescent experience of psychiatric treatment that came from this NIMH study, and I'm going to talk a little bit about that, particularly in relation to persons who are having distress related to psychotic experience. The specific aims of our study I'm going to outline in a moment, as well as some of the methodological orientations that we have, and the conceptual ones as well, along with a few findings that we can do within the limits of time. This is our research team. I was co-PI on this. Excuse me. You can see that we are an interdisciplinary group with clinical psychologists, child psychiatrists, both of them doing our kids SCID interviews for diagnosis, social workers, medical anthropologists, and many more undergraduates who worked on the study, helping to code a voluminous amount of research over several years. The NIMH aims of this study were to look at, as Nick mentioned at the beginning, focusing on subjective experience, but also cultural meanings of illness and distress from multiple perspectives. We look at this from the perspective of youth. In this case, average mean age was 14.1 years old. Parents, one or more, depending on the household, or guardians, if there was a case of someone who had a legal guardian, and then an array of healthcare providers, including primary care physicians, but much more within a specific setting. We were a children's psychiatric center, which I'll say a little bit about more in a moment, with psychiatrists and clinical psychologists and social workers who worked with us on this study. And so we investigate what the problems are, the conceptions of the problem, defined from the perspective of multiple stakeholders, and to get at the subjective experience, the cultural meaning, the living conditions in homes and within communities. And as for all research projects, we do this with IRB and cooperating collaborators within the clinical setting. So I don't know how many of you have been to New Mexico, but if you have, you will have probably come across one of these signs: "Welcome to New Mexico, Land of Enchantment." It is emblazoned on the license plates of all of the cars. It's a very beautiful state. It's a very, in fact, is quite rural. It's very spread out, and to get around, you have to drive a great deal. This is also true next door in Arizona and all around the Navajo Nation, where to get anywhere usually takes a fair amount of time being in the car, but not so bad, as the surroundings are pretty geographically beautiful. This is a map of New Mexico that, for anybody that's just trying to get their geographic bearings, with Texas and Arizona over here and the border down here. And just to give you an idea of the research project, these are all of the areas that we went, hence my comment about driving. Our research team did a great deal of this, going all over the state to follow, in longitudinal follow-up, these kids who had been, after their discharge from their inpatient stays at the Children's Psychiatric Center associated with the School of Medicine at the University of New Mexico. So we would go all over the state. Albuquerque is a heavily populated area. Second most populated would be Las Cruces here in the south, but we were all the way up here in Raton. Santa Fe, people may be familiar with that, is over here. And just to give you an idea of what the type of work is, this is not lab work. This is work in the field, as anthropologists are known to do. And as I say, it's very, these are some of the Zuni Mountains. And while beautiful, it's important to bear in mind that in terms of child poverty, New Mexico ranks, depending on the year, in the last 3 years, second highest, first, third, fourth. It's really quite high, the extent of child poverty within the state, and how many people are really living on the edge with respect to economic survival. This is a photo I took in Albuquerque, one of many, many murals. There is within Albuquerque over 400 known gangs, that occupy street by street, and some of the areas are difficult to negotiate and to live in. One area is called the war zone. I have a couple photos from that in a minute. But it's very culturally diverse. Perhaps New Mexico is the most visibly, notably culturally diverse because of a large presence of First Nation, Native American populations, many different Latinx, Hispanos, Mexican descent, and other Latinx population, as well as many, many other culturally diverse groups, including Vietnamese, Cambodians, Kurdish. This is a very popular Mexican restaurant. This is the Albuquerque Indian Center. This is pretty small scale compared to what they have on the res in the Navajo Nation, a few hours away from here. This is the Highway 66, right along this major strip that has actually been used in a lot of Hollywood films. The Desert Sands Motel. Some of the kids lived at some point in and around this area. I took this photo in 2016, but by the next few months, it was looking like this. And then at the very end of 2016, there was a fire and it was burned down and it was actually demolished. So this doesn't exist anymore. This is one of the homes of one of our research participants in the south of Albuquerque, and in a town called Belen. This geographically gets us out about 10 miles northeast of Santa Fe. And you can go, Santa Fe, of course, is very beautiful, very wealthy, and is a site for a great many tourists to go and visit. But if you just get up and out, even as much as 10 minutes, you could come to this neighborhood intersection, and it's actually a small intersection, but directly across from this mural is this one, which is Sur 13, which is the larger, more generic name for a enormous, in terms of numbers, gang with several subcells that dominate a lot of the area. This is in Albuquerque, the Children's Psychiatric Center, directly across the street from the University of New Mexico School of Medicine, where I have worked on different research projects, including this one, for several years. And the medical director of this center is really quite marvelous and really interested in broadly in an interdisciplinary approach to understanding health, wellness, illness for children and adolescents. And they were also very interested, the staff who we worked with a lot, the providers, in what happened to the kids after they had a stay at the Children's Psychiatric Center. What happened to them? Where did they go? Because that was something that, of course, the clinicians could not follow up on. They couldn't do that. So we did, and would go back and provide summaries, not of course about any specific individual, but about our findings in general and what we could say within the bounds of confidentiality. So the approach to this study is similar to others that we have done, insofar as it is interdisciplinary and that it's multi-method. In with respect to collecting qualitative ethnographic observations and interviews, a lot extensive, very long interviews, very open-ended, to get at everyday experience, what led to the current hospitalization. I should say that while the mean age of these kids is 14, the vast majority of them had been hospitalized multiple times before and had been in some kind of treatment or care since very young. I don't have all of the instruments that we used for the assessment, but it's rather extensive. We did follow up between 1 and 2 years, contingent on how easy it was or wasn't to find and locate the kids and their families after they left the hospital. In the end, for the full follow-up, we had 47 out of an initial 60, despite best efforts. We would go to Colorado, we would go to California, we would go to Arizona, we went to Utah, we would go anywhere within a reasonable geographic distance to be able to follow them up, but we could not do that in all cases. Some of them were lost. We just lost track of them, or we would get somewhere where they were supposed to be and they had just left. So it was some of the kids we just missed, or we lost them to follow up. Now, in terms of, I'm going to spend a few minutes on our conceptual orientations, because this is, I think, where our work is distinctive and different from most research that you have in psychiatry department. And certainly I can tell you in my own home department, we're interested in culture and cultural processes, and I'm going to say very quick bit about each of these concepts. Lived experience, extraordinary conditions, which is a formulation that I coined a few years ago, and the notion of engaged struggle. And that came from a kind of analysis that was derived across several studies that our research group has done. With respect to culture, this, you have these debates within training programs and within med schools about the extent to which the cultural formulation is or is not taken into consideration for training and then ultimately for practice. But I think that one of the most important things, this is a slide from a previous conference that I attended on study of psychiatry and culture, and it had to do with what is culture, what does it mean, and what I see primarily is the way in which culture often goes unrecognized. It's always there for all of us, just as is mental health and illness. It's simply not well understood or well recognized. First of all, let's say what it's not. It's not a variable, which is a real bummer to a lot of my psychology and psychiatry colleagues, because they just want to measure it. And I've had lots of debates with them about how that's just not going to work out. It's not an ethnic or racial designation. That's not what culture is. It's not a place. It's not a nation state or a people. It's not a fixed or coherent set of values, beliefs, or behaviors. That's usually how you hear about culture. Now, that may be disconcerting to some, like, well, wait a minute, this is getting really out of hand. Well, what culture is to the best that I can try to describe it to you from my own studies and research and understanding, is that this is an orientation to the world that is actively created and recreated. It's not static. In the process of social interaction, and it has to do with the meanings that we take for granted. And there's a lot of patterning to it, but there's also a great deal of individual variation. And it's what we pay attention to. It's what matters to us and to groups of persons, sometimes shared. And it's also about who matters. And it's also about who doesn't matter. These are cultural orientations. And over here on the bottom, I have the cover of a book by Arthur Kleinman, What Really Matters, Living a Moral Life Among Uncertainty and Danger, which is really quite excellent. Now, this is a slide with way too many bullet points, but let me just point to a few. What we do know after several decades of empirical research, interdisciplinary research that is anthropologically informed, is we know that culture makes a difference for mental health and illness in several ways that have been demonstrated empirically. Certainly for risk and vulnerability factors. Also for type of onset. This was noted by the World Health Organization in the late 1970s with the publication of the International Pilot Study of Schizophrenia, and variations in, particularly in a rapid or sudden onset versus gradual, or we'd call it insidious onset. And there's, of course, huge differences in recovery patterns for type of onset. So it's important, and it's much, much more common to have a sudden or acute onset from which there is relatively rapid recovery within a few days or a couple weeks in other parts of the world. I'm thinking right now of a lot of the work of my colleagues, Byron Good, in Indonesia as one example that he's been doing now for 17 years continuously, with including early onset interventions, which is quite interesting. We also know that the symptom content and the form and the constellation, that those symptoms that tend to go together vary a lot transnationally across cultures. Clinical diagnostic processes, I'm not talking about research, clinical research diagnoses, but clinical diagnoses in the community, of course, vary in relation to cultural factors. Subjective experience, kin identifications of conception, and social and emotional responses to the problem. Now that, I would have to say, is a place where Nick's research and my own, intersected. The idea that what we were working on at the time was expressed emotion, and the fact that to recover or to improve from having had a serious psychotic episode for which one is hospitalized, it really is very important the type of social environment in which one returns. And if that environment is dominated by negative or hostile affects, including criticism, as opposed to warmth and positive remarks, it makes, when you look at aggregate analyses, it's very robust, the findings, it makes a big difference for who gets better and who does not. Now, this is really common sense, but of course, we're health and social scientists, and so we have to, find this out in detail for ourselves. And the other factor about the social emotional, or say expressed emotion response to persons by kin has to do entirely with what they think the problem is, their conception of the problem. So if they think the problem is, in the case of Mexican descent immigrants, one of nervios, which is not anybody's fault. It's something that is very common, and it's an idiom that encompasses a great range of distress that is very human and very understandable. In those cases, it's much more likely to have a response of sympathy and tolerance, as opposed to rejection or hostility. And sometimes that can happen if people understand the problem to be like a personality deficit, such as laziness or a lack of initiative, or somehow blaming the person for some personal deficit. And then the last one on this slide, the course and outcome, I think that's really the most important of all, because what we care about is what we can understand, all of us together, about what helps to improve, to be healthier, and have happier lives. And we know that expressed emotion is one part of it, not all of it by a long shot, but it's one part of it, as are conceptions of the problem. Now, lived experience as a concept is something that we're hearing more and more about these days. You hear it all the time. We've been hearing it the last year about COVID. You can't understand this unless you have it from lived experience. Even Vice President Kamala Harris has been saying, talking in relation to, she wouldn't understand that if it wasn't for her lived experience. So this is something that's been around in anthropology, or psychological, really I shouldn't say anthropology, psychological and medical anthropology, which is the kind of anthropologist that I am, psychological and medical anthropologist. It's been around for a long time, but it's receiving a lot of everyday currency in common discourse now. And we think that it's a very important area of focus, so that we have person or patient-centered experience. We have multiple perspectives, and that I have argued for some time now. But this is really crucial as we try to identify what are evidence-based treatments, what is an evidence-based approach that would include, from a methodologically rigorous perspective, subjective experience and lived experience in particular. The theoretical model that we're working with here is the reciprocal production of something that I've called extraordinary conditions. This goes back to some early work by Edward Sapir and Harry Stack Sullivan that were looking at psychosis and some of the symptoms of psychosis as possibilities on the continuum of human experience. And that is how I look at it. And that some visual hallucinations could be from the perspective of persons who are not voice hearers, do not hear voices. It could be looked at as, spectacular. Spectacular is a different word than pathological, but it's like there's a possibility, human possibility, Homo sapiens, that one can hear voices. And this is a personal experience, and it's certainly, while of interest to researchers in this way that I've just described, I'm certainly by no means denying or wishing to downplay the distress and the suffering that often, usually, accompanies that, and is wrapped up in various diagnostic categories that we use as researchers and clinicians. And then On the other side of this subjective personal experience, we have social conditions of adversity, structural violence. There are several different forces of structural violence, which include racism and discrimination, social stigma, discrimination, and I'm going to argue scarcity of services for mental health as another one of the pieces of structural violence, because it is a question of political will and how we treat people. And this has been written up. This book came out in 2015, Extraordinary Conditions, Culture and Experience and Mental Illness. And the thing about anthropologists and some other social scientists is that we write books and also journal articles. We do both. So it's not as one of my neuroscientist colleagues said, "Oh, isn't a book? Isn't that something you do? After you retire and you're just reflecting on your memoirs?" No, these are very empirically based sets of studies that we put in books. Now, struggle is another concept that I came to in trying to think about what connected the various projects that I've been involved with over the many decades now. And seeing that it was perhaps more productive to focus on struggle than symptoms for a variety of reasons. One is that it's a fundamental human process of engaging possibility. And I've seen this with refugees from Central America, persons living with psychosis or living with hearing voices and being very distressed by it. And yet, and this is what is quite fascinating to me as an anthropologist, and yet, not in all cases, but I'm going to say most, the desire and the struggle to improve, to get better. So this is foregrounding the notion of struggle, including that with adolescents. I'm going to have to rush along here. This is a clip from, this is actually the first person that out of the 60 that we had in the New Mexico study, a pseudonym Tassiana, and I did this interview. And before I got the informed consent done, and without even asking questions, we have a semi-structured interview guide, and I couldn't even get to it. She, a very slight, soft-spoken young girl who sat across from me, just launched into a very commanding narrative. And this is, she said, "I am Zuni. I come from the other side of the mountains. I come from Zuni. I came here," it's the Children's Psychiatric Hospital, "because bad things happened to me, and some people told me I could come here to rest. People could take care of me. This is my first time coming here or in trying to commit suicide. I hate myself because I hear voices, like voices telling me what to do." This was her uncle and her grandfather who she was hearing, and who had, both of whom had died, telling her to come and be with them. Now, out of the 47 for which we have the full follow-up data, you'll note here that the vast majority are, this is not their first hospitalization. I'm not going to refrain from saying rodeo. They've been hospitalized before at other places around the state. I have to say, hands down, from the perspective of these kids and their families, that the Children's Psychiatric Hospital, Children's Psychiatric Center, it was later renamed, is the best care that they had received, and they were very pleased about it. The problem was that with changing managed care requirements, increasingly the stays were getting shorter and shorter. This is a source of great frustration to the clinicians and the therapists who could not conduct the kind of therapy that they knew would be helpful because they didn't have the time frame. So, and then with people being discharged to residential facilities, many of them for profit, and far inferior to what the kind of treatment and care that they were receiving at the Children's Psychiatric Center. This is a chart of difficult life experiences and gender. The females and the males, perpetrator of violent acts, had they done something? The majority of them had committed some sort of destructive or violent act, nothing criminal, or they wouldn't have been in the hospital, in this particular hospital. But one of the most interesting things here is there really are not sex differences. It's not as though males are more, significantly more likely to score within that category. Now, I hasten to say these are very small numbers, so this is really descriptive. Suicide attempts, well, that was a very common way or reason for being hospitalized, but you'll note, of course, that the girls were more likely, again, very small numbers, to have been hospitalized because they had a suicide attempt, legal trouble, alcohol, self-cutting, physically abused, sexually abused. But I'll just bring your attention. I'm going to have to really whip through the rest of this very quickly, given the time that we have. It is the mean number of these types of difficult life experiences by gender. There were several of them. So most of these kids had multiple things going on. Now, the KidSKID diagnosis done by our child psychiatrists and our clinical psychologists were trained in reliable administration and rating of this, shows that, something that we're really quite familiar with. Girls have depression at roughly twice the rate as the boys did. And that's the most common diagnosis. But we have also anxiety disorder. Since these kids were about 14 years old, for the psychotic disorders, making full criteria, which is, the SKID criteria is a really pretty high bar to make. We had 10 out of the 47 who made criteria for psychotic disorders. We had several more who were subclinical, subthreshold, that are not in this chart. But again, the interesting and not unexpected, but certainly problematic, is the mean number of diagnoses and the comorbidity here for girls and the boys, and how very common that was. Now, this is a clip from Tassiana, who I read to you just a moment ago when she was in the CPH, and then she had been discharged to a residential facility, and she had a very different narrative than she was Zuni, and she came from the other side of the mountain. She came here because she effed up her life. She did it to herself. She can't do anything right. It's a very individual focus, as opposed to, I'm Zuni, I came from the other side of the mountains, I'm here because I need to rest, people could take care of me, people did bad things to me, and she had been severely abused in a variety of ways. So right now I'm working on my depression, my anger, my hallucinations, and my self-harming. And I've processed a lot of this and tried to use my coping skills. This is from a different study, but focused on subjective experience of a psychotic related disorder. In fact, this Sebastian was diagnosed with schizophrenia. There's a whole chapter on him and his very complex lived experience and phenomenology in extraordinary conditions. He struggled for a really long time to figure out where the voices were coming from. And as we know, sometimes the voices change over time, and they had at a certain point morphed into one voice, a male voice that he decided was the voice of God. And this was really distressing. He did not have a good response to meds, and then ended up refusing to take medication because they had such a negative effect on him in a variety of ways. But he insisted that, in his words, that he was just like everyone else, except I hear voices. And that's a very important point that we would argue strongly that about the humanity and the being having any form, mild or serious, short-term or long-term type of mental health condition makes one no less human than anyone else. So what we see in these, when you're working in the area of subjective experiences, is incredible struggle for interpretation. What's going on? How do I understand this? And problems with trying to understand it as a chemical imbalance, which is the most common trope that people are told. Understanding what are psychiatric drugs for, how do they work? The struggle over, with respect to the meds, who's in charge? Me, the illness, or the meds? In fact, these are all intersecting dimensions. And as Nick mentioned at the outset, one paper, I have some references listed at the very end if anyone's interested, so they could get the precise sources from where did this research come from and where is it published. Lived experience of taking meds. This is an IMH study that I did on subjective experience in the culture of recovery. We had 90 people in this study. These were adults, and they were part of the first clozapine clinic in the US, and they had been treatment refractory for some time, but had, relatively speaking to prior suffering, very good response to clozapine. And 77% of them said that they felt that their medications helped them and they had improved because of the medications. So they were very tenacious about taking their meds. Nonetheless, all was not well, because while they appreciated that, a diminution of the voices, getting greater control, there were several problems in their everyday lived experience that they still struggled with. The idea of a recovery without cure. That's what they want. That's what people want worldwide, globally, when you look at this. Why isn't there a cure? And I would say, I have to agree with them. Why not? That's what, of course, we need to be working toward. And that's not what we have right now. And then existential social struggles like, if I take these meds, what are my options? I have to either choose to be crazy or fat. I choose fat. This has changed somewhat now as the metabolic effects of the second generation antipsychotics is better understood, but at the time of the study, this was not the case. And then I'll just mention the other one of this kind of cruel irony that while they felt better within the social world, they were not being treated better. They still felt very socially stigmatized, despite the fact that they themselves personally felt better and had improved. So I'm going to end now with a quote from Margaret Mead. Up there on the right, anthropology demands the open-mindedness with which one must look and listen, record in astonishment and wonder that which one could not have been able to guess. And also, she is very notable for having said, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. So moving forward, here's to engage listening, to advance and to grow our shared kinship, to improve care, health outcomes, and to abolish social stigma and discrimination. And I have a couple of pages here of references that, should anyone wish to go and look at some of the sources for the research that I touched upon very briefly. And with that, I'll end. Thank you.
Well, thank you, Dr. Jenkins, for a wonderful presentation. We have a couple questions that have come in already, which we'll start off with, but people can continue to submit these to me in the chat. First question is, have you explored or can you speak about the cultural experiences for patients that are children of first-generation immigrant parents?
Yes, the cultural experience, can you just give me the first part of that again, Nick?
Have you explored or can you speak about the cultural experiences for patients that are children of first-generation immigrant parents?
Yes, yes. We have many such children in the current study. That's a very complex thing and has been in the last few years in particular, because of the political climate and being quite apprehensive families about seeking care. Some of our first generation families are documented, some are not. We usually know that, but we don't ask it specifically. And so I say that simply because that does influence the experience. But what I do find is with the Mexican immigrant families that they're really very keen to seek services and to accept them if they are available, and go to great lengths to find those. It's always a family affair that, you know, multiple family members coming in with a child who are involved and very concerned. And we have had some that are, you know, very early onset psychosis and get referred for treatment. But the cultural dimensions of that have to do with language and, you know, familiarity within you know, being in a new country, and separation from some family who are across the border still. And that has certainly been, I would have to say, one of the biggest sources of stress for both the kids as well as the families overall.
So the next question, I think, is in a very similar vein here. How have experiences at the border or crossing the border influenced people's engagement in healthcare?
Mm. Well, we've had a really tough time, and that is definitely the case right now at this very moment. We have 4,217, I'm not sure the exact number this morning, unaccompanied minors who are in the process of being relocated where they are temporarily to either go to relatives, and that could be anywhere in the country, or some kind of temporary foster care. There is the experience with providers for people who have been crossing recently is generally really positive. We have from UCSD med school and local community services like Jewish Family Services. We have UNHRC. We have a lot of different parties involved with trying to provide help. They're very interested in receiving the help and very grateful for it. The problem has been that people move pretty quickly, and there isn't that much time to do any kind of treatment or interventions before they can be gone, they can be moved. So this has been a big challenge for the providers who can't, do, it's a full workup. So, the first thing is, primary care to do an overall health examination, and then also, of course, mental health. But we are seeing, we don't have the data for this yet collated, but we are seeing very, very high rates of stress, anxiety-related conditions, including trauma and PTSD, from the parents that are bringing them, as well as among the kids. And some, it's too early to say, but some psychotic-like experiences as well in some cases.
Okay, I think we have time for one last question here. The last one actually it has a comment and a question. So the comment is, thank you for such a thought-provoking talk. And the question is, what do you think accounted for the change in Tassiana's narrative?
Yes. Well, we have she's in a different place, in a state, is in New Mexico state. The particular facility that she was in is now no longer in business, I'm glad to say. It was closed down for state violations. They don't have a high level of professional training for those who were working there, but to use a word that sometimes gets overused, you see this move from a sense of self that is social and connected to, as very common for Native American persons, to the land and to the landscape, and to people, to an individualized neoliberal view of things, that if something is wrong, it's your fault. Very focused on the individual, and very harsh and very negative, saying that she messed up her life. And I think that, the idea was, this is all you, and this is considering that the problem is you and how you're coping with things, rather than the conditions in which you live in, the people with whom you're connected. It's a different kind of narrative. It's not a sociocentric and in place or home, rooted in the landscape, in the mountains, etc., notion of self to a very demarcated individual who is responsible for everything, her or himself or themselves, and they are, it's all on them. And it was not good care, and she did not have a good experience there.
Dr. Jenkins, thank you for a wonderful presentation today. And thanks everyone for joining us for this week's presentation. We hope that many of you can join us next week when we have Dr. David Kimhe, who's going to be talking about exercise interventions among individuals with psychosis. Hope everyone is staying healthy and safe, and we'll look forward to seeing you next week. Thank you again, Dr. Jenkins.
Thank you. Bye-bye.
Bye, everyone.